layout of the lecture, we will introduce to brain hemorrhage and intracranial hemorrhage, then imaging, traumatic hemorrhage, non-traumatic hemorrhage, and try to draw some conclusions. So the first thing, when actually we are analyzing a case, we are going to look to the cause of the hemorrhage. And we are going to divide it in two major groups, the traumatic ones and the non-traumatic ones. And then regarding each of the groups, we are going to define if this is epidural or subdural extraaxial hemorrhage, if it's subarachnoid, intraventricular, or if it's a parenchymal hemorrhage. And by this, then, we follow and look into the possible causes of each of the type of hemorrhage. So regarding the traumatic ones, they are mostly located at the epidural space, subdural space, so epidural, subdural hematomas and brain hemorrhagic contusions. Non-traumatic, you can have at the brain. In adult population, the hypertension and cerebral amyloid are the most common causes, especially in the elderly. And the vascular malformations are more common in the young people, and venous thrombosis also. And there almost 15% of the cases of brain hemorrhage results from the hemorrhage from a tumor. Subarachnoid hemorrhage, non-traumatic, most of them are due to are caused by the rupture of an intracranial aneurysm. And then there are other rare causes of subarachnoid hemorrhage that we are going to see. So CT is generally the first imaging method that we use for evaluation of brain hemorrhage, and it's important to look at the topography of the hemorrhage, the extension of the hemorrhage measured by diameters, and associated complications. And the associated complications are mainly the mass effect, especially if there is a brain herniation, as in this case with right side middle shift, and intraventricular extension with hydrocephalus. So actually the predictors of worse outcome that we must report are the size, intraventricular extension, hydrocephalus, and regarding topography, the ones that are at the infratentorial location, especially at the brainstem. CTA may be very useful at the acute phase, especially in the case of subarachnoid hemorrhage, to look out for the cause, the rupture aneurysm, or in cases of bleeding in a young patient to rule out a vascular malformation. Magnetic resonance, we are going to use it more to define the etiology of the brain hemorrhage. So how does the hemorrhage looks in the different stages? On the acute stage, we are going to have a hyperattenuation, as you see here in this pontine acute hematoma. And as the hematoma maturates, it will actually in the first hours increase in the attenuation levels from more or less 40 to 80 ounce-filled units to 80-100. And afterwards, you are going to see a hypodense rim at the periphery of the hematoma due to a serum extrusion and edema. Well, in the hyperacute stage, the hemorrhage may actually be hypodense. As you see here, this was an hyperacute epidural hematoma, and you see the more acute blood is not hyperdense because it's not, the clot has not retracted. Fluid levels, when we see it inside a brain hemorrhage, we must think that two possibilities. Active bleeding, so we are looking into fresh blood coming into the hematoma, or the patient has a coagulation disorder and, of course, has an acute bleeding. Another sign that is important at the acute stage is the spot sign when you do a CTA. And the spot sign means that you have extravasation of contrast from the vessels inside the hematoma. And you see here the anterior cerebral arteries, and you see some extravasation there inside the hematoma. And this predicts hematoma extension, and also it points out to the leakage point where there is the bleeding. And you see in this case, magnified view, you see the spot sign there, and you see that the patient continued to bleed from that point. As we go further for the subacute phase, we have isoattenuation, so iso-dense lesions. And you see here, this may be actually particularly difficult to see in subdural hematomas. And you see that there is bilateral subdural hematomas, and the density of the hematoma is almost the same as the cortex. As you go into the chronic phase, it goes into a hypodense area. In the brain, hemorrhage can also be associated with calcification, dystrophic calcification, and brain atrophy and malacia. On MR, imaging of the blood is a little bit more complex because we are going to have different phases, and these different phases from oxyhemoglobin to desoxyhemoglobin, methemoglobin, intracellular, extracellular, and then on the chronic phase, hemosiderin, they will all look different. Obviously, if you see this image with hyperintensity on T1, hyperintensity on T2, this is the easiest diagnosis that you can make, and this is extracellular methemoglobin. But it's not always the case, and there are some different stages that we actually need to look into. And this will help us not only to measure the timing of the bleeding, but also to understand if there is an underlying lesion or not. Because normal brain hematomas will follow this evolution. And when you have tumors or other lesions that may bleed, there is not this regular evolution from the acute hemorrhage with intracellular desoxyhemoglobin, and I call you the attention that this will be low signal on T2 images, high to low signal on T1, and this is actually the same signal intensity evolution as a thrombus inside an artery or a vein. And then you have the early subacute hemorrhage with the intracellular methemoglobin. So the methemoglobin starts to become hyperintense on T1 and still hypointense on T2. And as we go to the extracellular methemoglobin, it will be hyperintense on both of them. Then on the late phase, we are going to have a scar of hemosiderin that is mostly hypointense on the different sequences. The hyperacute phase, we generally don't see that, but it may also cause a problem of diagnosis. But you should remember that it's going to be hyperintense on the T2 weighted sequences. And special attention when you are looking to the flare images or dark fluid images to see that subarachnoid hemorrhage may present with a high T2 or flare dark fluid signal in the subarachnoid space. Well, the brain hematoma itself, we actually need to look at the evolution of edema and mass effect. On the acute phase, they will both increase independently of hematoma expansion or not. So there is an increase of the edema from the early hematoma. Hyperacute hematoma does not have edema, and as you go on the first week, it's going to increase the edema, especially during the first 48 to 72 hours. On the chronic phase, there will be no edema, of course, there will be no mass effect, and you are going to have a scar that you can see it on the MR as the hemosiderin. And this scar in the MR, it's important to look into brain hemorrhage. Contrast enhancement, when there is a normal spontaneous primary hematoma, there is or can be a ring enhancement at the periphery of the hematoma. And this does not mean that there is an underlying lesion. There is a peripheral inflammatory reaction surrounding the brain hematomas that will give you contrast enhancement. Okay? But it's linear and ring around the hematomas. You see here the images. You see typical hypertensive basal ganglia hematoma. You see the CTA with no vascular abnormalities whatsoever underneath, and you see the evolution to the chronic phase where you see this slit-like sequela surrounded by a regular and complete ring of hemosiderin, and still in the inside some extracellular methemoglobin. Well, regarding the traumatic lesions, we are going to have the hypodural hematoma. They are generally associated with fracture and to the laceration of an artery, which is a dural artery. Sometimes there may be hypodural venous hematomas, but they are less common. And you see it here, like with this typical shape and with association of fracture. You see another one with the typical biconvex lentiform shape. They do not cross sutures, but they can cross the middle line, the falx and the tentorium. As you see it here, it's the same epidural hematoma that has a supratentorial and infratentorial component with some air inside, meaning that you have a fracture there, and with an acute component that is still not hyperintense on the CT. Subdurals, they are located between the dura and the leptomeninges, are also most commonly traumatic, and the most common cause is the venous rupture. And they are associated with a higher mortality rate because they are more common in elderly patients and patients with coagulopathy. And you see it here, the typical shape of the subdural hematoma, as you see it here, associated with a significant mass effect. And so they have this crescent shape. They have a concave inner border. They do not cross the midline, you see here, because there is the falx serrae that does not allow it to cross the middle line, but they can cross the sutures. They may have multiple layers, meaning that these hematomas have bled several times, and they go from hyperdense to isodense and hypodense on CT. Brain contusions, you know that they can be edematose, as you see here, edema on the lower frontal gyrus, or hemorrhagic, as you see here, with hemorrhagic lesions associated with edema. They are more commonly located at the temporal and frontal lobes because these are the areas that actually are crushing with the bone at the anterior fossa and also at the petrous bone. We need to follow up because most of the times the edema and the hemorrhage can occur not at the acute phase. Just one mention to diffuse axonal injuries. These are lesions that you don't see often with CT. There are two types. Just one is non-hemorrhagic and typically has restricted diffusion, and the other ones are hemorrhagic that you see just like these small, low-signal dots in typical locations, as is in this case in the midbrain and corpus callosum. Regarding a non-traumatic brain hemorrhage, so the most common causes are chronic hypertension and amyloid angiopathy. And amyloid angiopathy, especially in the elderly population. When we go to younger patients, the most common causes are vascular malformation, especially brain AVMs. Then we need to think about many other diseases. Tumors, there are typical primary and secondary tumors that bleed, coagulopathy, and you remember that there is many patients that are now under antiplatelet therapy, double antiplatelet therapy, and in anticoagulation. And you should remember also the consumption of some drugs that may cause vascular lesions with hemorrhage. Cerebral venous thrombosis has frequently an hemorrhagic presentation. Vasculitis may present with hemorrhage, moya, eclampsia, and press, and so forth. So then we can actually divide it between the age group and in the adult, the most common are hypertensive hemorrhage and cerebral amyloid. Be careful, sometimes we image the acute ischemic stroke not in the acute phase but on the subacute phase, and they may have hemorrhagic transformation. Dural AVFs, we are going to see in another lecture, are also more common in older patients, and you think also on coagulopathies. Young patient, you should think on brain malformation, vascular malformation, and venous thrombosis. In pediatric, it's different. Again, vascular malformation, venous thrombosis, and the possibility to have hemorrhagic tumors. So hemorrhagic strokes correspond to 10 to 15% of all strokes. They have a high mortality rate. You see 30-day mortality almost reach half of the patients, and most of the deaths occur during the first 2 days, and this is due to the mass effect associated with this hemorrhage. The 1-year survival is actually very, very low. Again, just to remind you of the outcome predictors, some of them are related to imaging, and we should report them on our reports. And those predictors are intracranial hypertension and brain herniation, hydrocephalus, and on the case of subarachnoid hemorrhage, the presence of arterial vasospasm. So regarding hypertensive hemorrhage, the location is the key point. So the most common location is at the basal ganglia, at the puttamina, and then at the thalamus. So puttamina here with the extension to the pallidus and to the white matter and into the ventricle, the thalamic one here, and then you may have central pontine hemorrhage at the cerebellar hemisphere and subcortical at cerebral at lower location. But these first two ones are actually very typical of hypertensive cause. When you do MR, and this is not acute hemorrhage, but it's old hemorrhage, you may see the microhemorrhage that you only see on MR. And the typical thing about hypertensive disease is that it affects as a central location, so as the location of the basal ganglia and thalamus and brainstem. Of course, you may also have subcortical, but if you only have subcortical microbleeds, you are going to think about amyloid angiopathy. So when you are reporting, you need to look at the volume of the lesion and the mass effect, intraventricular extension, the possibility to have hydrocephalus, and you should repeat imaging, not only if the patient has a clinical deterioration. If that is the case, you should repeat the imaging, but in any patient, because the hematomas, they continue to expand in almost more than 1/3 of the cases during the first day. And if you think that the population that we are imaging are elderly patients that may have some brain atrophy, on the initial phases, this expansion of the hematoma may go subclinically, and you may miss the timing for making the right treatment as a ventricular shunt. Cerebral amyloid angiopathy, the diagnosis, the definitive diagnosis is by pathology, but imaging is becoming more and more important for this diagnosis, and these are the modified Boston criteria. And most of the cases are sporadic, so they are not familiar. There are very few cases that are familiar. And how do you suspect of amyloid angiopathy? If you have lobar hematomas, as in this case, subarachnoid hemorrhage that you are going to see with hemosiderin, microbleeds at the peripheral location, and also you are going to have small vessel white matter disease and brain atrophy. So the typical location of the microbleeds on amyloid angiopathy, peripheral, not central, and not the brainstem. Vascular malformations, we are going to deal this also in another lecture. So cavernomas may bleed. Mostly they bleed inside. They are venous malformations. They bleed inside the lesion. This is an exceptional case that had a bleeding that go outside the cavernoma. Venous thrombosis, you see bilateral lesions. When you see bilateral lesions, and especially hemorrhagic, think that you may have a problem on the superior sagittal sinus. As you see here, you have the complete superior sagittal sinus thrombosis with bilateral hemorrhage, or with an hemorrhagic infarction, so typically from venous lesions. Many other causes may cause brain hemorrhage. You see here a patient with moya-moya disease and with a deep-seated hematoma due to the rupture of this anastomosis of the lenticular striates arteries. Important about tumors, because this has a different management. There are the most common hemorrhagic tumors are metastases, and this comes from the breast and lung because they are more frequent. But think about melanoma, choriocarcinoma, renal cell carcinoma, and thyroid. And primary are the GBM, as you see here. You have no doubt that this is a tumor. Hemangioblastoma, in this case, with a fluid level. They also may bleed because they are highly vascularized. How actually we suspect of an underlying tumor? A typical location. So we have seen the location. Multiple hemorrhagic foci inside the lesion. Heterogeneous hematoma. On MR, it's not going to follow the sequence of events that we have spoken before. Fluid levels, incomplete hemosiderin ring, irregular margins, as you see here, larger edema that was for the size of the lesion, and non-hemorrhagic enhancing areas that are actually the solid component. So this was a melanoma metastasis, as you see, very different from the typical hematomas. And on the follow-up, you see the edema continue to increase and not decreasing on the late phases as a normal brain hematoma. And now you start to see the solid portion of the tumor that is enhancing. The follow-up is in this intraventricular tumor actually will show you, you see a hematoma, heterogeneous, and you do the follow-up and now you define clearly what was the lesion, intraventricular lesion that has actually bled. Vascular intraventricular hemorrhage, they are rare. They are more commonly associated with vascular malformations, brain EVM or dural AVF. In this case, a brain EVM with deep venous drainage into the deep venous system with intraventricular hemorrhage. And they can also be secondary to extension of a brain hematoma that rupture inside the ventricle. Subarachnoid, just to mention that we may have traumatic ones, as you see here, that has foci of contusion and subarachnoid hemorrhage, or associated with a rupture of one aneurysm. Just remember that the CT is the best method to make the diagnosis, especially during the first 24 hours. Then the accuracy will decrease, and to look for subarachnoid hemorrhage, or you do an MR, or you do a lumbar puncture, and you are going to look for xanthochromia in the CSF. You have to evaluate it by the Fisher grade, so everybody can communicate. We are going to skip this, but you have the table, and you actually can report on this. If you have a spontaneous subarachnoid hemorrhage, you are going to look to the cause of the hemorrhage, and most of it is an aneurysm. So the patient is already in the table of the CT. You do the CTA, and you depict the aneurysm that needs to be treated as soon as possible. So intracranial hemorrhage imaging is essential for the diagnosis and classification, for the evaluation of the underlying cause, and this MR is very important, to establish the prognosis and appropriate management, and to monitor the evolution, and to detect the complications, especially at the moment that we can be helpful for the patient. Thank you very much for your attention.